Thank you everyone for coming. My name is Robert Steele and I'm a professor here in the Department of Philosophy at UNO and a member of the Medical Humanities Faculty as well. It is with pleasure that I can welcome you to the first inaugural event in our new Ethics of Medicine lecture series here at UNO. Every last Thursday of the month at 7 p.m. Central, yours truly will be moderating an hour-long Zoom event featuring a scholar in medical ethics applying their cutting-edge research to pressing contemporary problems. Now, putting together a series is a bit of an undertaking, and when it comes to this one, there are a lot of people to thank, but I'd like to specifically thank the Ted Kuser Health Humanities Center for their financial support, as well as Courtney Kopetz of the College of Arts and Sciences for her invaluable work in building our web presence, advertising, and really getting this event to actually run. For this first talk, we are very excited and honored that Dr. David Wendler will be presenting to us. Dr. Wendler is the head of the section on human research ethics in the Bioethics Department of the US National Institutes of Health. He's widely published in prestigious venues and a leading figure in research ethics. His work has, in some though not enough places, even managed to help shape the federal regulations. So it really is a treat to have him out. And today he's here to talk to us about the ethics of enrolling children in COVID-19 vaccine trials. So the chat for this event has been disabled, so you can't ask questions through the chat, but we do have a Q&A function, and I encourage you to put your questions into Q&A. We have time reserved after the talk at the end, and we do hope to have a robust discussion then. We also have a couple questions pre-registered from people, and I'm excited because those questions are pretty great, but we'll get to those at the end. So without wasting any more of anyone's time, with that, I will hand things over to Dr. Wendler.
Thanks, Robert. It's a pleasure to be here. And for the inaugural one, my goal is to not completely screw this up. So you guys, when you're doing some months from now, you can say, you know, it's great now. And the first one wasn't even really that bad. So it's a pleasure to do this and a pleasure to work with Robert. We have a fellowship program in our department, and Robert was one of our truly wonderful fellows a few years back. So it's great to be able to join with him again. So I'm going to try to do at least two things in this talk. I'm going to talk, as the title suggests, about the ethics of enrolling minors in vaccine trials for COVID-19. But I want to use that as just one example to talk also more broadly about the ethics of pediatric research and the ethical issues that it raises and how those are illustrated by the question of enrolling in COVID-19 vaccine trials. So this might start a long time ago. I think I'm trying to remember, but I was sometime in junior high school and I thought that I learned that doctors were really smart and doctors were impressive people. And I somehow, maybe I was sort of too much of a philosopher back then, but I got the idea that the way doctors figured out whether some new medicine or treatment would work was they just sort of looked at the biology, maybe the molecular structure of the medicine, and they knew lots about the human body, and they could just sort of figure out whether or not this medicine would work for these people and for this disease. And what I learned, not fully until I got to the NIH, was just doesn't work that way. It's too hard. Medicines and the human body and diseases and illnesses are just too complicated. And at least still no one's figured out a way to assess, determine whether or not a particular drug or treatment or intervention or a vaccine is going to be effective, except for one method, which is basically to give it to people and see what happens. So that's the challenge. The way we learn how to make medicines that work, the way we learn how to develop new and better medicines is we just give them to people and we see what happens. So that's what brings us to clinical research. And the way we do that is we do research studies, and clinical research has been incredibly important to the improvements over the last 40, 50 years that have been made in a wide range of areas of treating diseases better, curing diseases, and avoiding diseases. And the way we typically do that is we run a clinical trial and we just ask people to give consent to be in the trial. It's harder when you start thinking about trying to enroll children, and for reasons we'll talk about, obviously there are ethical challenges with enrolling children in clinical trials. So on the one hand, if we're going to learn what works for children and what doesn't work for children, if we're going to learn what's safe and what's not safe for children, we have to try it in children. So we need children to participate in research, and getting children to participate in research helps us to improve medical care for all minors, and that's a good thing. But the challenge then is which minors, which children, and at least for the purposes of this talk, if people have questions, I'm going to use minors and children roughly interchangeably, just to mean somebody under 18 who can't give informed consent for themselves. How do we do that? So we need to test new treatments for children to improve medical. Yep.
Cutting in for a second. Do you intend to have been sharing your slides right now?
No, okay. This is all pre-slides.
Pre-slides, good.
This is all I didn't have any slides on this, so I thought, actually, for anybody who cares, I'm visiting my mom in Florida, so this is my mom's screen. There's actually a nice lake in the background, but it's now dark here, so I wasn't going to be able to show that to you guys. So what we need is we have a dilemma. We need to test treatments in children. That's the way we improve medical care for all children. But it's a question of which children do we enroll in the trials in the first place? How do we decide which children to go into our trials? And that's a challenge because children can't consent, and these trials pose risks and burdens to them. And so it's a question of ethically, how do we test things in children to improve medical care for all children? So that's the background. Now we're going to go to my slides, and Robert's going to tell me whether or not, hopefully, this is working. I'm trying to go full screen. Okay, look, that looks okay, Robert?
Magnifique.
All right, so that brings me to our topic, which is the ethics of enrolling minors in COVID-19 vaccine trials. As Robert said, I work for the US NIH, but the views that I'm going to express in this talk are simply my own. They don't represent the position, the policy of the NIH, the Department of Health and Human Services, of which NIH is a part, or the US government. So I'm going to start a little bit of background on vaccine trials and minors. So I don't need to tell anybody here about the challenges that the COVID-19 pandemic is presenting to our health, to our economic lives, to our social lives, to our psychology, to our social lives. It's terrible, and we need an effective response to it. And in order to get an effective response, we're going to need to get enough people vaccinated, and that includes minors. So we need a vaccine that's safe and effective for minors, and that raises our critical question for today, which is, when is it ethical to enroll minors in COVID-19 vaccine trials? So here's the tension. If you wait too long and you just do your trials in adults first and continue for a long time just doing your trials in adults, it's going to take a long time before you study minors, and that's going to mean that you're going to delay an effective response to the pandemic, maybe by months, maybe by years. On the other hand, if you enroll minors too soon, there's a worry that you don't know enough about the vaccine you're testing when you enroll minors, and you might be exposing the minors to significant risks. So that's the tension. So why is that a concern? Why is the challenge of enrolling minors too soon a challenge? And there's two worries. One worry is that minors, just based on their cognitive capacity, are less understand, or at least most minors. I'm going to come back and qualify this in a little bit, but for now we can say most minors have less understanding of research. For instance, minors, if you talk to 10-year-olds, they tend to have less understanding or less appreciation for long-term risks. And as a result, they're less able to assess themselves whether the risks of a given study are acceptable or whether or not they're excessive and they don't make sense for them. And in addition, minors are just not able to give their own consent to being enrolled in research. So that raises ethical concerns about enrolling them. So given these two challenges, the way research ethics works and the way regulations for pediatric research work is that there are these extra requirements. So there are these baseline requirements that apply to all research with competent adults. But then when you want to enroll minors, there's some additional requirements that you have to satisfy. So the first one, to address this concern regarding excessive risks, So for instance, the US regulations will only allow minors to be enrolled in research when either the risks are very low, and later on we might want to talk about what counts as very low or sufficiently low risks, or if being in that study offers the potential for participant benefit. So that's a way of trying to address the concern about excessive risks. And then in terms of consent, as I mentioned, minors aren't able to give valid consent for themselves. And so what most regulations, including US regulations, require is that at least one parent, so the S is in parentheses here because at least under US regulations, sometimes you need just one parent, and in other cases you need both parents. And in addition, minors who have the capacity to make decisions to a certain extent for themselves, you're required, in most cases at least, to get their positive agreement. And that's what in the US regulations is called assent. So those are the additional requirements that we're going to focus on for pediatric research. So how do you satisfy these requirements? Well, the standard approach with respect to vaccine trials is you do a very large trial with a lot of adults, and you wait to get sufficient evidence that the vaccine you're testing is both safe and efficacious or effective. Those words mean slightly different things, which we could talk about, but we don't need to really worry about it too much for the purposes of this talk. The basic idea here is you first test it in a lot of adults to make sure it's safe and effective before you enroll minors at all. The advantage of this approach should be obvious. If you're pretty confident that what you're testing is safe and effective, then that offers a pretty good way to protect the minors that you then enroll from being exposed to excessive research risks. So there's an advantage to that approach, but there's also a downside. And the downside is if you wait until you have both safety and efficacy established in adults, that's going to delay your ability to enroll minors. And as we said at the beginning, you need to test the vaccines in minors to get a good response, an effective response to the pandemic. So it's going to delay that effective response, possibly by months, possibly by years. So what do we do about that? Here's an alternative approach. You might think, okay, that's easy. Why don't we just enroll them right from the beginning? Enroll the minors at the beginning in the first trials before we have evidence of either safety or efficacy in adults. So that's problematic, as I'm going to talk about. So here's the proposal I want to consider. What about enrolling minors after you have safety but before efficacy? So is that an ethical thing to do? Okay, so that's supposed to be the background, basically think about minors being enrolled in vaccine trials. So now what I want to do before we think about that specifically is take a little bit of a step back and talk about the ethics of pediatric research more generally that will inform the way we think about that question. So here's the dilemma which has been suggested, what I've been saying so far. Pediatric research exposes some minor participants to risks in order to collect data that hopefully will benefit other children, typically children in the future. And since the 1970s, with the work of the National Commission, there's been very significant debate over whether and when it's ethical to enroll children in research. The National Commission, for people who are interested, was a body that was set up subsequent to the disclosures of the Tuskegee syphilis studies that was charged with developing recommendations for new regulations for research with human subjects. And the recommendations of that body basically became the basis for the current US regulations that we have now. That commission did an amazing job. They delivered a lot of reports. And if you read the reports, they'll tell you that the most difficult challenge that they faced, and the one for which there was the most controversy, was whether and when it's ethical to enroll children in research, the exact question we're talking about today. This is one of the prominent legal cases that looked at this question. It's called Grimes v. KKI. KKI is the Kennedy Krieger Institute, which is a pediatric research institute in Baltimore that's affiliated with Johns Hopkins University. They were doing some trials in the mid-1990s. Some of the parents of children enrolled in that trial sued the Kennedy Krieger Institute. Grimes refers to the mother of one of the children who was enrolled in the trial. And basically what that court ruled, this was the appeals court, the highest court in the state of Maryland, basically ruled that children should not be placed in situations of potential harm. So you shouldn't have children face any risks in the context of research studies to learn things that might help other people, even if their parents consent to it. So the Grimes court took a very strict ruling that exposing children to any level of risks to learn things that might help others was legally and also ethically, they thought, inappropriate. That's supported by data, and I'll be interested what people in this audience think about the ethics of pediatric research in general. So there's a lot of concerns with this. So these are just two related studies that were done about 15 years ago now that showed about half of people you survey. This was people in the UK, pediatricians, also in Canada, and then also Canadian medical students. And about half of those people said either you shouldn't enroll children in research or you should only enroll them when there's a chance of benefit to the children themselves. So exposing children to risks for the benefit of others, these people regarded as at a minimum ethically problematic. So what do we think about these? I'd be interested, and hopefully we'll have a chance to chat about what other people think about these views. And so what we want to do, or at least as a philosopher, what I want to do is I want to think about, okay, is that the right way to think about exposing children to risks in the context of pediatric research? How can we figure out whether or not or when that might be acceptable? So one way I think about that is to think, okay, let's stop thinking about research for a second. Let's think about other areas, other contexts, other parts of life. And let's consider what counts as appropriate treatment of minors in those contexts. And then let's apply the lessons we learn there back to the questions that come up with respect to pediatric research. So when, if ever, is it ethical to expose children to risks for the benefit of others outside of research? And what I'm going to argue is that this is actually a fairly common and widely accepted practice. So here's an obvious example. There are just countless examples you could come up with of charitable activities that involve minors, individuals under 18 years old, where at least most people think it can be acceptable to have the children face some risks in an activity that's designed to benefit others. So these are just some examples. I'm sure other people can come up with others, but charity car washes. So a lot of high schools where I live do charity car washes to collect money for charity. Mowing the lawn. So you ask your 15-year-old to mow the lawn of an ill neighbor, or if you live in the north, or maybe even in Nebraska, maybe it's actually shoveling snow from the sidewalk of your ill neighbor, or having your children go door to door or sell cookies to collect money for the victims of a natural disaster. So that seems acceptable. And so one of the questions is research different? Is there some reason to think that while that might be acceptable outside of research, it's ethically problematic in the research context? So one of the ways we've been trying to answer that question is just to ask parents and the minors themselves. What do they think about having minors exposed to risks in charitable activities versus research? Do they think one is ethically more problematic than the other? So I'll just give you a little bit of data. I don't want to bombard you with too much data. We could talk about more, but here's just one study that we did about 10 years ago. What we did was we took a bunch of teens who were participating in research studies. They were between 13 and 17 years old. We interviewed them, and we also interviewed their parents separately. And one of the questions we asked them is, we said, all right, here's a specific level of risk. Would you be more willing to face that level of risk to help other people in a research study or in a charitable activity? And here are the results. Most of the people, both the parents and the teens, said it didn't matter. They were equally willing to help others and face some risks in the context of a research study or a charitable activity. And then if you look at the second or the third row there, prefer research, at least with respect to the teens, the ones who had a preference, more of them preferred participating in a research study to help others than they did a charitable activity. So that, for us at least, gives some reason to think, if you assume that these charitable activities are acceptable ethically, then given the views of these parents and minors, at least they don't see research as more problematic in some fundamental way. Another thing we've learned, and this is some results from the study we did, is that in addition to being willing to do this, there are ways in which at least a lot of minors feel as though they get some kind of personal benefit or psychological benefit from participating in studies. So same study that I just had on the previous slide, 80% of the minors in that study said that they felt proud to participate in research to help others. So at least older minors really do feel like they can embrace this and like being part of these valuable projects. So what are the implications of that? So what I want to suggest is, at least suggest, it doesn't show, but at least suggest that pediatric research can be ethically acceptable when it's consistent with or satisfies similar conditions that apply to appropriate charitable activities. So what are they? We could talk about some more of them, but these are the most important ones. The activity, whether it's a charitable activity or it's research, should have important social value. You should be, if it's research, studying an intervention that could be important. If it's charity, you should be helping people, for instance, who really need to be helped. At least in most cases, there should be a good reason or a need to enroll minors. You shouldn't just enroll minors because it's easy to enroll them, or maybe they're more likely to say yes. There should be a good justification for enrolling minors. And the third one is that either the risks should be very low, or in some cases, this isn't necessarily true of most charitable activities, but in research at least, there might be cases where the potential benefits to participants justify risks that are higher than that standard. Okay, so that was a little brief detour into the ethics of pediatric research. So I want to bring the lessons that we learned there back to our question about when, whether it's acceptable to enroll minors in vaccine trials for COVID-19. So here's just a quick reminder. What was the challenge here? We have an obligation, both as individuals, as parents, and as a society, to protect minors from being exposed to excessive research risks and excessive risks in general. So we should protect them from risks. At the same time, if we wait too long, in particular, we wait until there's evidence of safety and efficacy in adults before we enroll minors in vaccine trials, that could lead to a significant delay in treating a pandemic that's killed over 400,000 Americans, and unfortunately doesn't seem to be relenting. At least hopefully it will, but not anytime soon. So that's the challenge. So here's the opposite approach. You might think, well, if the delay is a problem, why don't we just enroll minors from the beginning? Why don't we enroll minors in vaccine trials before there's any evidence of safety or efficacy in adults? That would certainly minimize the delay. Now, of course, the challenge is that that has the potential to expose children to excessive risks. If we don't know whether or not that vaccine is even safe at that point, we might be exposing children who can't consent to excessive risks. So this is what we've been endorsing, a kind of intermediate approach or a short delay. We know that enrolling minors only after safety and efficacy in adults poses a significant delay. That's what I started out with. Then we're just suggesting that enrolling minors before there's evidence of safety or efficacy may pose excessive risks. So here's the proposal. What about enrolling minors after there's safety data in adults? You have sufficient reason to think it's safe in adults, but before you have evidence of efficacy, before you have evidence that it works in adults. And of course, for a vaccine, what that means is that it's protective against the disease. So here's one thing, I don't know if people who are aware of some of the ways in which these trials are done. I think one reason why this makes sense is compared to most drug trials, for reasons that are required, and we could talk about this more, why this is about what it takes to establish the efficacy of a vaccine. It's harder to establish the efficacy of a vaccine than it is to establish the efficacy of a drug. And as a result, to overcome that difficulty, the way these trials are done is they're big, they're very big. So a drug trial might have 800 or 1,000 people. That's a reasonable size, fairly large drug trial. That would be a minuscule vaccine trial. Vaccine trials enroll 30, 40, 50, 75,000 people. So one of the advantages of that, of course, that makes these trials a lot more difficult to run, makes them a lot more expensive. But one of the benefits for our purposes is if you enroll that many adults, now these are placebo-controlled trials typically, so the number who are actually getting the vaccine is typically half to 2/3 of that number, but it might even be 20, 25,000 people. And if you give 2 doses of the vaccine to 20, 25,000 adults and you wait a couple of weeks and you haven't seen any concerns of safety, that doesn't prove that there are no concerns of safety. For instance, there might be long-term risks or very unlikely ones you haven't seen yet, but it's pretty strong evidence that this is going to be a safe intervention. So how would you implement that approach? So the basic idea is we suggest you take it a little bit slow. So first what you do is you start with minors who are most similar to the adults from whom you collected the safety data. And in most cases, that means 16, 17-year-old adolescents who physiologically are pretty similar to most adults. So what you do is you start with a small group of them. And another advantage of that, one of the challenges, I always talk and try to scold people who work on pediatric research ethics, is when we talk about medicine, there's this mantra that you shouldn't think of all children the same. A drug that works in a 16-year-old may have no effect or may have the opposite effect in a 3-year-old. And I think ethically, we need to remember the same thing. There's a big difference ethically between enrolling, say, a 16-year-old in a clinical trial versus a 2-year-old. And there's empirical data to support this, which suggests that older children, typically children over 14, are able to understand and often understand clinical trials to the extent that your average adult can. So if you start with those and you get their assent, their positive agreement, and also the permission of their parents, I think that provides pretty strong protection. So now you've got both the parent and the child agreeing, and you've got good safety data. Although not a guarantee of safety, but good safety data in adults. And I think then you have an ethical justification for enrolling children. So as I was mentioned, you start small and slow, so you can further minimize risks by beginning with a smaller number of older and healthy adults, adolescents. And if you don't see any safety concerns, you then enroll a larger group of older healthy adolescents, and you can repeat this with younger adolescents. And thought is there are some minors who are potentially going to face greater risks. Ethically, we're more worried about younger children who can't understand at all and can't give their own agreement at all to participate. And also minors, typically ones who have comorbidities that put them increased risk for severe disease. And we wait till we have the healthy adolescents and find safety in them before we enroll the riskier minors. Okay, so that's basically our suggested approach to the question of when you enroll minors in vaccine trials for COVID-19. So just to summarize that, it's critical that we develop vaccines for this pandemic. It's critical that these vaccines are safe and effective and include minors. The standard approach, which makes sense ethically, of not enrolling them until there's safety and efficacy in adults, leads to a significant delay. You might think, okay, we have to accept that delay if there's no appropriate alternative, but I've tried to argue there is an appropriate alternative. How is that? Well, the real concern here isn't whether or not there's going to be potential benefit to the minors from being in the trials. It's the worry about exposing them to excessive risks. And the suggestion is we can address that by waiting until there's safety data in adults and then starting with the minors who are most similar to the adults. And then basically, this is what people call, they call it age de-escalation. So you start with older adolescents and then you progressively enroll younger ones. Okay, so thanks for listening.
Thank you, Dave. Very interesting and enlightening. I'd like to remind everyone that the Q&A is open. So if you have questions, then please do put them there. I have a couple of clarificatory questions first, one of my own and one from the Q&A. So something that's notable about your proposal, Dave, is that you're balancing two different concerns that pull in opposite directions. You want to go fast, because the faster you go, the faster you get the vaccine out, the faster the vaccine's out. We all benefit tremendously in our health, welfare, ability to go back to our lives. Just every possible good thing is going to come out of that.
Yep.
So anything that slows it down also is bad, because we get all of those benefits later and suffer some irrevocable harms in the meantime. Okay, so want to go fast, but we also don't want to expose children to excessive risks. We're not going to go fast by trampling across their tiny selves if at least we can ethically help it. Okay, you recognize though, so you do this intermediate thing, you wait for the safety data, but not the efficacy data. And this balances these two concerns, but one can always ask, why not go more extreme in either direction? Why not strike the balance in a different way and just say, okay, we have to wait because it doesn't matter how socially beneficial it would be. You just can't impose uncompensated risks on children who can't consent for themselves. You could also say, no, in fact, when the benefits are large enough, you can impose that risk on them. And in fact, you can impose even a little more by just starting out immediately in children without waiting for that safety data either. And to me, so it seems like a key part of your argument for splitting the difference in the way that you do, that the wait with your proposal is really short. You start getting the good safety data like a few weeks into these huge trials, and you could have the trial in minors all teed up and ready to go, like you're just waiting to pull the trigger on it after that initial safety data comes in. So it's a short wait for information that tells you a lot about safety, right? And so that's part of why this is the intermediate place to pick.
Exactly.
The best of both worlds, not either of the extremes. Okay, so that was just me clarifying, making sure I understood.
That was a very nice clarification.
Why you're asking, or why you're setting things the way you were. Okay, sorry. And questions are coming in the Q&A, which I love. Also, one initial like logistical question. So this is being recorded, and everyone who comes will get information about where to watch it later or to find it. Everyone who's registered will be able to access the recording later, including the people who registered but didn't even come to be in the event live. So don't worry about that, or like feel like you need to desperately take notes or whatever. You'll be able to come back and watch it later. So another question, this is also a sort of like background factual question about how much safety info you have at different times. So we have a question, where does animal research fall into this? Does animal research ever play a role in deciding safety and efficacy before enrolling minors? Or does adult testing always occur prior to minors to obtain that data first?
Right.
So like, could you do enough to protect them from excessive risks by having a really robust animal model or good animal data?
Right. Good question. So I don't know how long your series is going to run, Robert, but I want to propose a session on animal research and animal research ethics at some point. I think this is it's a great issue. And so the standard response is that data just from animals is almost never regarded as sufficient to go right to minors. There are some exceptions to that. So you might think of a case where you have a disease that just doesn't occur in adults at all, and you might have to start in minors. But the standard response is that simply having really good safety data in animals isn't regarded as sufficient to start in minors. You typically still start in adults. And I should say now this gets a little too beyond our scope and gets into the next animal research session you guys should do. But part of the reason for that is that animal models a lot of times just aren't that good. And things that have been safe in animals have turned out to not be safe in human beings, and the other way around. Things that have turned out to be dangerous to animals have turned out to be very safe in human beings. So it doesn't typically give you the kind of data that you'd be comfortable with to say then enroll a 4-year-old.
Okay, so animal models aren't going to do it on their own. They may give us some data, but the data is so bad compared to testing in adults first that in order to protect the kids from excessive risk, we got to do the adult testing.
Right. My old boss, who was the head of our department, was an oncologist, and he used to say the number of times that cancer has been cured in mice is just absolutely uncountable. But just doesn't often and rarely translates into effectiveness and safety in humans, unfortunately.
Okay, so we're not going to do it with animal models. So I had a question. It seems like your take on your own proposal is that it does involve putting children into what you would call net risk research.
Right.
So research where the level of risk from the medical intervention is higher than the expected medical benefit of the intervention.
Right.
And hence, if you were only thinking about the child's interests and only their medical interests, then you would not, for their sake, enroll them in that research.
Yeah.
That's why it's the analogy to charity, because it's the important dimension is that they're doing something socially valuable and helping other people. And that's what justifies it, not their medical interests narrowly considered.
Exactly.
Yes. Okay, good. So if we are, oh my goodness, if we are doing that.
Is the audience throwing things at Robert?
I just lost a lens.
Oh no. Are you okay?
I am okay.
Okay.
We'll get through this together.
Some of the questions might be read in a very interesting way.
Yeah. Okay, so there is some level of narrowness, you think?
Yes.
And so that's the medical risk, but children are also able to be benefited and harmed in all sorts of different ways outside of their medical health. In fact, in the paper in Pediatrics, which this talk is, I believe, based on, you highlight that, look, even if some kids do have serious COVID reactions, and that you shouldn't assume that it's impossible for them to die, and some have died, and so on. But most don't. Still, the benefits to them in terms of being able to go back to school, easing burdens on their family, all of that. There are all these like life and welfare benefits that could come with mass vaccination of children.
Right.
They're really important. So we shouldn't just think of the little medical bit in isolation, which leads me to wonder if even if the research is net medical risk, if it might be overall net benefit with a sufficiently capacious understanding of what's good for a child, particularly if we take measures to try and enhance those other outside benefits. For instance, we make sure that kids who maybe their parents are struggling with childcare, the researchers could pay for that. For instance, you're having trouble with daycare, your kids are at odd ends. We can supply that for you in kind goods. And other similar benefits to try and make it so like, look, even for the kids' individual sake, we think there's a little bit of risk here, but we're doing enough stuff to help you out that even for the kids' sake, it's a good deal.
Yeah.
Is that possible, do you think? Is that a strategy researchers could use?
So let me try to answer two versions of that question and see if I got what you think is the most interesting version, or maybe there's a third one. So the first one involves one way I was trying to set this up is almost to think about pediatric research is involving a kind of collective action problem where it's good for all children as a group, to do this research to identify, and we could talk about vaccines, but this at this point, it's not limited to vaccines. It's treatments for pediatric cancer, for pediatric rheumatoid arthritis, for pediatric diabetes, for just on and on. We need better treatments for a lot of diseases that affect children. So doing the research is beneficial to children as a group. Children are better off if we do this research. And if we stop doing it completely, all children would be worse off. So there's this benefit that children get from us doing this research, completing this research, and identifying better things. The challenge is that typically for the children that you enroll in the studies, they'd be better off basically if they weren't enrolled, but you enroll somebody else's kid. So I think technically in a lot of cases, if you were thinking only about the best medical interests of your child, you wouldn't enroll them. You'd try to convince your neighbor to enroll their child, for instance. So I think we need to appeal to the willingness of parents and adolescents to think beyond their medical considerations and participating in these trials. So I think that would be my answer to the first version of the question. The second version, I don't know if you're asking this one, Robert, is there are things you could do beyond medical benefits to make participation in one of these trials in the interests of minors. So for instance, we wrote a paper a long time ago where we talked about the ethics of paying children. So maybe you could think, yeah, sure, it's not in their interests the way you have the trial structured right now, Dave, but why don't you just say, okay, we're going to pay each of these children $1,000, $2,000, $5,000. And wouldn't that make it in their interests to be in these trials? That I think is a great question. As Robert knows, I think that's a hard question. I'll just say a couple things about it. One of the things I think is interesting is most people who do research ethics, as Robert knows, get very nervous when you talk about paying people to be in trials. I think that's a mistake. I think clearly paying people in a lot of these trials would be a good thing for them. I think there are a couple of complexities that come up when you think about enrolling children. The first one I'll say is just a complexity about paying, which I hope we're not getting too complicated and in the weeds too soon in your session here, Robert. We're going to scare people away. But right now, the standard view is that people who participate in trials typically don't get, so they'll get compensation. Actually, compensation is fairly common, but they don't get a lot of compensation. But notice these are trials that will lead to the development of drugs that literally make companies billions of dollars every year. And I think that that setup is itself ethically problematic. And I think that participants deserve more of a share in the benefits that result from the trials that they participate in than they're getting now. So for me, I want to say it's not these specific children. I think everybody should be, who participates in these trials, should be sharing, not as sort of an incentive to get them enrolled, but just to get their fair share. So that's the first thing. The second worry with children is just, I think that it's not completely inappropriate to think about paying them. The problem is we need to think about ways of structuring the payment to make sure that it doesn't turn out inappropriate. What we really don't want is we really don't want parents enrolling their little kids in research to make money for themselves. And we need to figure out a way to do it that protects against that.
Yeah. So my thought was, it's all well and good to ask people and their children to fall on their swords for the good of society and be in some net risk research. But that's not the only option we have. And if we have this other alternative where we try and sweeten the deal and make it good for them, maybe we're obligated to do that. This does raise concerns, though. And for instance, one of our pre-registered questions was, are you worried? I'm paraphrasing, sorry, I don't have it open in front of me. But are you worried, particularly for adolescents, about compensation and that this may distort their decision making? So this person in this question said, my friend's kid got into a trial, they paid them $1,000. Is this problematic? You know, when I was 16, it would have been like jazzed for $1,000.
Right. So I have a rule when I give a talk that I'm allowed to give two unrelated anecdotes. So here comes the first one. We have a bioethics consultation service, as Robert knows, and we get ethical questions in the hospital. And there was a study that was doing these MRIs, these images of healthy 10-year-olds, and they were going to pay them $100. And the review committee was very worried about the ethics of this, and they asked us to go up and to talk to the kids and make sure that they weren't feeling pressured, that they understood, they realized that they could say no. And I talked to about 10 of these kids who are being enrolled in this trial, and every single one of them I talked to them was just jazzed about the money that they were going to get. And all they talked about was what they were going to do with it. One kid was going to buy a skateboard, and the other kid was going to buy this access to all this great music. So it is definitely an incentive for these kids. I think there's no doubt about it. And I guess I would say, if the only protection for adolescents was the decision that the adolescents themselves make about whether or not to enroll in these trials, then I think I might be, or I probably would almost certainly be worried about this prospect, but it's not. And what the adolescents decide is actually a very minor protection in the scheme of things. There's two much more important ones. The first one is there's review committees, which in the US are called IRBs, it stands for Institutional Review Boards. They have to sign off on the studies as not only being important, but having acceptably low risks. And then also the parents need to agree as well. So my hope, at least the assumption is that those are the protections which would kick in and would keep children from being exposed to excessive risk, even if the children were willing to take them on. And I think we do know there are worries. People, when you fan, not just kids, you fan $1,000 in front of people and they'll make decisions that they later regret. So it is a worry and we need protections against it.
So this is another question that's on a related note, which is why I'm pressing it on you now. One thing you can do to sweeten the pot or balance the risks or whatever is to, compensate people as they join, give them money or other goods or services they wouldn't have had otherwise to make their lives overall better as a result of having been in the research. And that compensates them for the risk. The risk that's relevant is the risk at the time of joining, which is generally a tiny chance of a very bad thing happening later.
Right.
And so you can compensate them reasonably for that, partially because the chance is in fact tiny. So on standard ways of thinking about how to make a decision, it's not so bad to take a tiny chance of a terrible thing. But that's still, if we're enrolling a ton of people, some of them are probably going to have the bad thing happen.
Right.
They're going to have the really bad result later.
Yep.
One thing we could do is have the researchers be responsible for insurance and medical care for people who do have the bad thing happen. Mm-hmm. So the researchers could be obligated to have long-term follow-up with the children, which maybe they should just have for safety and other data anyway. But also, when something bad happens, healthcare isn't free in America. The researcher has to step up and pay for it.
Yep.
Do you think they're required to do that? And do you think it's ethical for them to run a vaccine trial and not do that?
I love that question. So are they required to do that legally, practically? In practice, no. Ethically, I think absolutely yes. So I think, and this just isn't my view. I think there's just a consensus view in our field that if somebody participates in your research and contributes to it and something bad happens to them as a result, that the researchers, the funders, the sponsors have an absolute ethical obligation to take care of them to the extent that they can. For reasons that I don't fully understand and I've never had well explained to me, this is a requirement in a lot of the world. So in Europe, you can't run a trial until you get an insurance policy that covers you. And it just doesn't happen in the US. It's never been made a requirement and it's still not, and it should be. And if anybody knows somebody out there who's got a lot of power who can change things, talk to them. It's a mistake and it needs to get fixed. And absolutely, they should take care of these people in every case when they're hurt as a part of the research. It's just right now not a legal, not a regulatory requirement, and it should be.
I figured you would say that. So a note to the participants, we've got like 10 minutes left and there are 20 open questions currently in the Q&A. So I do deeply apologize if we don't get to your question, but I'm doing my best. I'm picking things out. I see one here that I think is, I get to decide. I'm going to ask about this one because I'm interested to hear what you would say. So
you are asked, I did tell you to ask me the easy questions at the beginning of this, right, Robert? We did agree to that.
You shall not be so lucky. So ancillary research questions with vaccine trials, such as what is the level of asymptomatic infection among vaccinated participants, can involve additional uncomfortable procedures. Mm-hmm. The subject will not directly benefit. Where do these procedures fall?
Yeah, so I'll tell you, in terms of the risk-benefit assessment, there's an approach to doing risk-benefit assessment for pediatric research that's commonly referred to as component analysis. And so the idea, and as this question is rightly pointing to, research studies tend to involve basically a package of lots of different interventions. So you might have to get 3 blood draws, you have to come to the clinic 5 times, you get 2 exams, you have to fill out questionnaires. There are a lot of different things that go on within any given research study. And so the idea is what you're supposed to do, and what as I mentioned, the groups that review these studies called IRBs do, is you look at the risks and potential benefits of every single one of those individual interventions, make sure they're appropriate and justified, and then you put the whole thing together and look at the risks overall. And the reason why you have to put that all together, for instance, is you can imagine a study that has a lot of very low risk procedures, a lot of individual blood draws and things, where each individual procedure doesn't pose a lot of risks. But if you put it all together and it's, I mean, just to give a philosopher's exaggerated example, if it's 500 of those, you're going to get to the point where your study is excessively risky. So you need to look at both the risks of the individual procedures and the risks of the package of the study as a whole. That's really important.
I have one here that I promise I didn't plant, but I definitely want to see before we close, as we are approaching near to the end. We are worried about putting minors at risk with these trials, but doesn't delaying the release of a vaccine increase the risk of contracting and possibly dying from COVID-19 for all children by leaving them unprotected for a longer time? How is putting a number of children at risk from a vaccine trial any worse than allowing all children and all adults to be at risk of contracting COVID-19 for longer than necessary?
Nice. So the only thing I will say about this question is I don't believe, and I will never believe, that Robert didn't somehow plant this question into the audience. So that's a great question. So here's one way to think about it. So let's let's not think about vaccines for a minute. Let's talk about a drug trial for children who, for instance, have type 1 diabetes from when they're little, and they get various treatments for that condition. What we've been talking about is clinical trials to try to develop new medications that are more effective and safer for those children. And what we pointed out is there are very strict risk limits on those trials. You basically can't expose children to risks in these trials, except for very, very low risks, unless there's a potential for benefit. But as this questioner, I think it's one of Robert's best friends is my guess, but as this question is pointing out, but in the meantime, if you're not doing these trials, there are doctors who are giving these drugs to children who are sick. And if the treatments aren't as safe as they could be, or not as effective as they could be, these children are suffering. They're suffering in very real ways, in very concrete, real ways. And so then there's the question of what's the difference, right? What's the difference between exposing a child to risks in the research setting, where I've been saying the allowable risks are extraordinarily very, very low, versus in the clinical care setting, where we're having sick children who are getting exposed to treatments that may or may not be effective. I mean, of course, this isn't true of all treatments. There are treatments we have that are perfectly effective and safe, but there are others that aren't, and we could do better. And the way to do better is through the research. So why is it then when we have children being exposed to all these high risks in clinical care, we can't allow higher risks in the research setting? That should definitely be the talk for the topic for another talk here. So I'll just tell you the standard view, and the questioner may just think this is confused. I think there's a certain extent, and rightly so, that Robert thinks it's confused. But the thought is that there's a big difference in the ethical acceptability of exposing a child to risks in the clinical care setting, when what you're trying to do is you're trying to benefit that individual child. And nobody thinks that risks are good or appropriate, not to be worried about in that setting. But the idea is at least there's some acceptability, because what you're trying to do, what that activity is designed to do, is to benefit the child. And that compares to a case in research where the activity is designed to benefit others. I mean, maybe what we could do, we need another hour or 5 hours. But as I said, one of the ways I like to think about these ethical questions in the research setting is to compare them to settings outside of research. So think about the risks that you're willing to expose your child to teach them something, to get them an education, to get them food, to get them housing, and compare that to the risks you're willing to expose your child to collect money for natural disaster victims or to help the ill neighbor. And the question is the level of risks pretty similar or not? And then what does that tell us about the different contexts and how do we apply that to research? But it's a great question.
I suggest briefly and saucily that this might some ways be a flawed test that you were suggesting. Think about what you would do for your kid, because I can also think about what I would do for myself, right? And I might be willing to throw 3 other people onto the railroad tracks in order to scramble off myself in time. And yet, when it comes to setting social policy, for instance, what sort of clinical trials will allow to go forward, whether I get to carry a card that entitles me to throw other people onto railroad tracks, my personal preference for myself is no great ground or argument in favor of a policy. And I'm not sure that the fact that we experience intense particularized attraction to our own individual kids is necessarily a great argument either.
Yeah, no, I think that's important. I was just trying to say, my guess is, at least for some people, they will see a difference between, it's not just that they're only not going to expose their own kids to risk in either setting, but they'll see a difference. But I don't know. Yes. Maybe what we need to do is set this up next time with a poll, Robert. You could do quick polls of people. This is going to get high tech.
Yes, this is also, to be fair, you set yourself out only as illuminating the thought behind the standard view. And I think you are completely correct about that. The standard view thinks that harming a child, imposing a risk being a kind of harming, get into the metaphysics of that or whatever, requires a justification. And the justifications in terms of the children's own benefit are unproblematic, because then you can just, metaphorically say to the kid, this really is for your own good and you're telling the truth. And when you're actually telling the truth, that's always a great reason. But harming them to benefit some other kids or some other people or whatever cannot be so justified.
Yeah, and I'll just sort of say, Robert knows this well, other people might not, that this is a really interesting area of when it's acceptable to expose others to risks. And even in the philosophy literature, it's an incredibly underappreciated, underexplored area. We expose others to risks just by living our own lives. And it's just really unclear when that's acceptable and not.
I think what the commentator picked up on did involve that the standard view involves an asymmetry between imposing risk versus not preventing risks. Which exactly. Totally comfortable doing. Okay.
Or it's even imposing risks in one setting versus another. Because when you give kid a drug, you're imposing risks.
I have to say, we're at 7:59. This room, I do believe, closes at 8. Thank you so much for joining us, everyone. Very wonderful. Sorry we couldn't get to all the questions. If you did like this event, please do join us also every Thursday, 7 p.m., end of the month. This is the first of 4 events. They're all linked to on the website, which had the link to this event. So please join us for our continuing Ethics in Medicine series. I'm so glad you were able to come out, and I'm so glad, Dave, you were able to join us for this one. Everyone, give yourself a big round of applause.
Great. Thanks, Robert. This is really fun. Thanks for having me.
Yes. Thank you so much. And
bye-bye, everybody.